Hello, this is Annette Weber from the University of Kentucky, and the following presentation will be reviewing the keywords for the IT exam uh, focused on the adrenal gland. We will be focusing on following keywords: Pheochromocytoma, adrenal gland insufficiency, gluco and mineralocorticoids, and effects of the laboratory values related to corticosteroids, aldosterone physiology and regulation, aldosterone antagonism and side effects, the overall humoral response to stress in patients who should or should not get steroid prophylaxis. So let's review the relevant facts of adrenal gland physiology. The adrenal gland has usually three arteries providing blood flow. The majority comes from the middle adrenal artery, which is a branch of the abdominal aorta. However, there's a superior adrenal artery, which is from the inferior phrenic artery, and the inferior adrenal artery is a branch of the renal artery. The venous drainage on the right side, the adrenal veins drain directly into the IVC. On the left side, the adrenal veins first enter the venal vein and then the IVC. Innervation comes from the celiac plexus, from the greater splenic nerves, and the sympathetic innervation comes from the spinal section of T10 to L1. The hormonal production of the adrenal gland, here you have to remember a little bit of histology, okay, because obviously there is an adrenal gland medulla and an adrenal gland cortex. And in the cortex, you see those zones, the zona glomerulosa, the zona fasciculata, and the zona reticularis. Depending on those zones, that's in the glomerulosa, that's where the mineralocorticoids are produced, hence aldosterone. The fasciculata, that's where the glucocorticoids are produced, cortisol, corticosteroids, and the reticularis zone produces the androgen hormones. The medulla, here that's where our catecholamines are produced, epinephrine, norepinephrine. So let's first talk about the glucocorticoids. Obviously there are endogenous produced glucocorticoids by the adrenal gland, but also we know a lot of non-endogenous glucocorticoids, which we give commonly in the pre-operative care period. Not only do you need to remember the duration, how long they act, but also which one of them are truly glucocorticoids and which one of them also have some mineralocorticoid action. So the core substance, cortisol, is the more short-acting version, so is hydrocortisol, and has about an equipotency, meaning the anti-inflammatory glucocorticoid potency versus the mineralocorticoid potency. Half-life is about 8 to 12 hours. Longer acting in either oral or IV form, prednisone and methylprednisone. Here you see a shift towards the glucocorticoid potency, and also they are longer acting. The dexamethasone, the glucocorticoid you most commonly give intraoperatively, has almost all glucocorticoid action, therefore anti-inflammatory, and has the longest duration, up to more than 2 days. So talking about the mineralocorticoids, the endogenous mineralocorticoid produced by the adrenal glands is aldosterone. Sometimes for patient care, we are using the non-endogenous mineralocorticoid fluorocortisone, as shown here in those in the red box. Aldosterone has only mineralocorticoid effect, fluorocortisone stronger than aldosterone, and less than 10% of the fluorocortisol action is glucocorticoid. Majority more than 90% is mineralocorticoid. So what does aldosterone do? Aldosterone regulates the sodium and the water hemostasis. It promotes the active sodium resorption and the passive, therefore the passive water reabsorption in the cortical collector tube in the kidney. In exchange to potassium, it facilitates the active excretion of potassium in exchange. You cannot talk about aldosterone without revisiting the renin-angiotensin and aldosterone system. It is a hormone circuit that regulates blood pressure, fluids, and electrolyte balance, as well as systemic vascular resistance. When the blood flow is reduced, the juxtaglomerular cells in the kidneys convert the precursor prorenin, which is already present in the blood, into renin and secretes it directly into circulation. The plasma renin then carries out the conversion of angiotensinogen released by the liver to angiotensin 1, which is then subsequently converted to angiotensin 2 by the angiotensin converting enzyme, which is found at the surface of vascular cells, predominantly in the lungs. Angiotensin is a very potent vasoconstrictor and therefore causes systemic vasoconstriction and therefore increases blood pressure. Angiotensin 2 also stimulates the secretion of the hormone aldosterone from the adrenal cortex. And here, aldosterone again causes the renal tubules to increase the sodium absorption, reabsorption, therefore passive, maintains water, increases the blood plasma volume, so therefore also addresses the blood pressure. In exchange, we are excreting potassium, so therefore losing potassium to maintain electrolyte balance. Reactions to stress are associated with an enhanced secretion of a number of hormones, including the glucocorticoids, catecholamines, growth hormones, and prolactin, the effect of which is to increase the mobilization of energy sources and adapt the individual to the new circumstance. The activation of the pituitary adrenal axis is a prominent neuroendocrine response to stress, promoting survival. Stimulation of this axis results in a hypothalamic secretion of corticotrophin-releasing factor, the CRF, and CRF then stimulates the pituitary gland to adrenocorticotrophin, the ACTH, and releasing lipotrophins and endorphins. The paraventricular nucleus of the hypothalamus is responsible for the integrated response to stress. Norepinephrine, serotonin, and acetylcholine mediate much of the neurogenic stimulation of the CRF production. So therefore, the stimulation of the pituitary adrenal axis is associated with the release of catecholamines. Stress also inhibits the thyroid stimulation hormone, the TSH secretion, through the action of glucocorticoids on the central nervous system. Therefore, the thyroid function is usually downregulated during stressful conditions. T3 and T4 levels decrease with stress. The growth hormone, GH, level is increased during the acute physical stress. Because of its insulin antagonistic effect of the growth hormone, it actually may enhance metabolic activity. As an anabolic hormone, insulin decreases during stress, and along with the increase in its antagonistic hormones, it can contribute to the stress-induced hyperglycemia. So let's talk about the steroid stress dose prophylaxis. Who needs it and what does it mean? If a patient is taking steroids in a supraphysiological dose for a longer period of time, chances are that your hypothalamus, pituitary gland, adrenal gland axis is suppressed. So what doses are we talking about? Okay, if a patient takes less than 5 milligrams a day, it's unlikely that the adrenal gland will be unable to produce enough cortisone required as part of the stress response. If a patient is taken 5 to 20 milligrams for a longer period of time, then it possibly could be suppressed, really depending on individual factors and duration of the therapy. The way how to answer the likelihood of this is the ACTH stimulation test. So you can give a small amount of ACTH and then check blood levels and see to what degree your cortisol blood concentration increases. That will tell you how responsive that axis is to hormonal stimulation. Someone has taken more than 20 milligrams a day for more than 10 days. There's a chance that the HPA axis may be suppressed. Also here, if in doubt, you can do an ACTH stimulation test, or sometimes you just have to adjust to what kind of stress response we're talking about. And if there's any suspicion, if your patient is symptomatic, you may opt out and give additional hydrocortisone. Again, here for the stress response, taking a glucocorticoid only is not appropriate. You do need to give a medication which covers glucocorticoid and mineralocorticoid action, something like hydrocortisone. So what happens if your adrenal glands don't work? Adrenal gland insufficiency. That means there's an inadequate amount of steroid hormones produced and effective. It can be on the level of the adrenal glands, the so-called primary adrenal gland insufficiency, or secondary, lack of stimulation from the pituitary gland, or tertiary, lack of stimulation and releasing factors produced by the hypothalamus. If this adrenal gland insufficiency occurs as an acute crisis and not only involving the adrenal cortex, then it's called the Addison crisis. That is different from the Addison disease, which is a congenital bilateral adrenal gland hypoplasia. The differentiation here is that with Addison disease, you also usually have skin pigmentation abnormality, bronze skin. Symptoms of adrenal gland insufficiency are hypoglycemia, dehydration, hypotension, weakness, and if it's in the form of an Addison crisis, abdominal pain. It can be triggered by stress as a relative inability to produce sufficient amount of steroid hormone, or, and that's where the stress response and stress dose of steroids comes to light, if it's corticosteroid withdrawal, meaning not taking replacing the exogenous amount of steroids the patient is used to. The laboratory values or the hallmarks you're looking for with adrenal gland insufficiency is hyponatremia, hypoglycemia, and hyperkalemia. Hence the aldosterone insufficiency. The diagnosis is made by symptoms, and you can use the ACTH stimulation test as your diagnostic marker. You measure the cortisol level before and after and see if there's an appropriate response. Treatment for it is straightforward. You give steroids, and again, dexamethasone as a true straightforward glucocorticoid is not sufficient. You need to use a corticosteroid which balances glucocorticoid and mineralocorticoid activity. So therefore you need hydrocortisone. So these are two syndromes where we have an excess of corticoid production by the adrenal gland or exogenous factors. Cushing versus Conn syndrome. So the Cushing syndrome, that's an excess of glucocorticoids, either due to a hormone-producing tumor or more commonly seen because patients taken high-dose long-term glucocorticoids due to other comorbidities. So the Cushing syndrome, there's this typical morphology, the buffalo hump, truncal obesity. Patients report about muscle weakness, hypertension, and they have diabetes, hyperglycemia. They also are hypokalemic, and they show a metabolic alkalosis. The laboratory values, in addition to a high glucose level, you measure the cortisol level, it's elevated, and your ACTH may be increased or suppressed depending on if it's on adrenal gland level, if it's exogenous. This one, obviously, ACTH may be suppressed, or if it's coming actually from a pituitary gland tumor, which also can cause this kind of imbalance. The Conn syndrome, here you have a mineralocorticoid excess. No morphology changes, but this patient will report polyuria, hypertension, weakness, and tetany due to the electrolyte imbalance. We have hypokalemia, hypomagnesemia, and sodium is retained. Again, here you have an overproduction on aldosterone. So potassium, your sodium will be retained, potassium will be excreted. They have a hypokalemic alkalosis. In a laboratory, you will find an elevated aldosterone level. So let's talk about aldosterone antagonism. Where we explore this concept with a pharmacological intervention is spironolactone, which is a potassium-sparing diuretic, and it works as an antagonist of the aldosterone activity. Spironolactone is used to treat hypertension, congestive heart failure, liver cirrhosis, and primary hyperaldosteronism. The side effect of using an aldosterone antagonist is, instead of retaining sodium and excreting potassium, it's the opposite. So therefore, you're going to see hyperkalemia, hyponatremia. As a diuretic, you still create dehydration. Patients may complain about weakness, hyperuricemia, the development of gynecomastia, hirsutism, hyperglycemia, and impotence are also related to not only the block of the mineralocorticoid receptors, but also androgen receptor. So due to the hyperkalemia spironolactone causes, you got to be careful if you use ACE inhibitors in addition to treat hypertension, because of the potentiation of the potassium-sparing effect, or if you combine it with other potassium-sparing diuretics like triamterene, because it enhances the hyperkalemia. If you combine it with prazosin, you have an enhanced hypotensive effect. Spironolactone acts as the P-glycoprotein inhibitor and therefore increases digoxin levels. And since spironolactone excretes sodium, it also increases the elimination of calcium and magnesium. Spironolactone blocks the androgenic receptors and therefore lowers the testosterone effect. That's how it causes gynecomastia, and estrogen level increases. That sometimes actually is used to treat amenorrhea in women. Other side effects, which are minor, is the dry mouth, nausea, vomiting, and the stimulation of hair growth has actually been used to treat hair loss in female patients. Pheochromocytomas are rare catecholamine-producing neuroendocrine tumors. They produce, store, and release excessive amounts of norepinephrine and or epinephrine, and sometimes even dopamine. While the majority of pheochromocytomas are located in the adrenal medulla, either unilateral or bilateral, they can originate in any other autonomic ganglia, then called paraganglionoma, which occurs in less than 20% of the cases. When the diagnosis of pheochromocytoma is made, there should be genetic counseling and family counseling because there is a genetic predisposition around this malignancy. Pheochromocytomas can be associated with other hereditary syndromes in other neuroendocrine tumors in about like 10% of the Pheo diagnosis that is observed. The conditions are multiple endocrine neoplasia type 2A and 2B. That's when it's associated with a thyroid carcinoma, in neurofibromatosis type 1, or von Hippel-Lindau syndrome, Sturge-Weber syndrome, or the simple familiar pheochromocytoma. Patients with pheochromocytoma, the classical presentation is the triad of headache, palpitations, and diaphoresis. Mostly known as an intermittent episodes, but also can be as a sustained release of catecholamines. Additional are non-specific symptoms like flushing, weight loss, tremor, orthostatic hypotension, hyperglycemia, pallor, fatigue, anxiety. In approximately 0.05 to 0.1% of all hypertension workup, pheochromocytoma is the underlying pathology. Pheochromocytoma crisis is a hypertensive crisis, rarely presenting as a hypotension episode, hyperthermia, more than 4 degrees Celsius, altered mental status, and other end organ dysfunction. That's the crisis. The diagnosis is made either by serum and or urine measurements of metanephrines and or norepinephrines. And as you see in this little graph, the metanephrines are the metabolites of epinephrine, and the normetanephrines are the metabolites of the norepinephrine. Pheochromocytoma is present when levels are elevated more than 4 times normal. The metabolites will indicate there's a catecholamine-producing tumor. If borderline, or if you need an increased sensitivity, you can do a clonidine suppression test, meaning you give an alpha-2 agonist, and therefore that increases the sensitivity of your catecholamine metabolite measurements, or if there was caffeine present, therefore a false positive, that also would clarify that finding. When a pheochromocytoma is diagnosed, so now here you have to treat the hypertensive situation. So to optimize and for blood pressure control, you first initiate alpha blockade. That's your first step, to block the alpha-1 receptor. The medication which is only used in that circumstance is phenoxybenzamine, which is the first-line agent. It's a non-comparative, irreversible alpha-1 and alpha-2 receptor blocker, therefore blunting the effect on the alpha-anaerobic stimulation. Phenoxybenzamine has a long duration. It's about, the treatment probably should be initiated 7 to 14 days pre-pheo resection. The side effects of phenoxybenzamine is nasal congestion, hydrostatic hypotension, dizziness, and reflex tachycardia. Another medication you could use are selective alpha-1 antagonists, like prazosin, terazosin, or doxazosin. Doxazosin is longer acting than prazosin. Has a shorter duration and action and less reflex tachycardia than phenoxybenzamine, because you still have an intact alpha-2 feedback mechanism, since they're only selective alpha-1 blockers. It's also a competitive blocking mechanism, so therefore it can be reversed by just overriding the alpha stimulation. Third line of medications here for getting SVR control are calcium channel blockers, either as a second agent if the alpha blockade is insufficient and you need a little bit more strength and synergism, or calcium channel blocker also can be used if your patient with a pheochromocytoma presents normotensive, which sometimes occurs. After alpha blockade is initiated and stable, but still insufficient, or you have reflex tachycardia, then you add beta blockade. Never use as a sole agent, because unopposed unopposed bladder blockade without alpha blockade would basically you need to override the vasoconstriction. Your target heart rate is 60 to 80 beats per minute. And then there's also alpha-methyl paratyrosine, which decreases the catecholamine production because it inhibits the tyrosine hydroxylase. Therefore, that is needed for the catecholamine biosynthesis. This drug needs to be taken for 2 to 3 days. It definitely deepens the decrease in hormone production, but significant side effects, somnolence, diarrhea, and extrapyramidal symptoms and anxiety. So how do you know if a patient with pheochromocytoma is optimized to undergo surgical resection? So-called Roizen criteria, which have been published in 1983. As listed here, no blood pressure reading less than 160 over 90 millimeter mercury within the last 24 hours. Patients should have experiencing some form of orthostatic hypotension, especially when getting up in the morning, etc. And the EKG should not have any ECG changes and not more than 1 PVC in 5 minutes. So these are the so-called Roizen criteria for adequate alpha-adrenergic blockade. You also may look for signs of volume expansion due to the alpha blockade. The plasma space, lower SVR, opens up, and so therefore the hematocrit drops, and so like signs of orthostasis. Patient undergoes pheochromocytoma resection, and then you have some post-operative concerns, which obviously lag to the tumor is removed, so therefore you don't have your endogenous catecholamine storms anymore. This patient is at risk for developing hypotension. So fluid, blood transfusions, vasopressors, and obviously rule out if there's bleeding. Patient also still may be in a hypertensive situation. Not all those endogenous catecholamines are eliminated immediately. It also can be due to fluid overload or, as they occur, disseminated or bilateral, there may be a residual tumor. Also, patients are at risk for hyperglycemia that also is secondary to the catecholamine effect. If a patient undergoes bilateral adrenectomy, this patient will need steroid replacement, and usually we start here with 40 milligrams of methylprednisolone every 8 hours. So here in this graph, just a quick review of the medications you usually only see associated with treatment of pheochromocytoma. So phentolamine as short-acting alpha antagonist, non-selective, but phenoxybenzamine, that's the oral agent, also non-selective alpha antagonist, irreversible blockade. And you see here the doses and also the half-lives. These are the concerns or hallmarks when you use phenoxybenzamine as the PO form and phentolamine as the IV form. Then alpha-methylthyroxine. Here, this is the inhibitor of the biosynthesis of the catecholamines. It takes a few times before that medication takes an effect. Obviously, this can be used as pre-management if a patient is not responding sufficiently to your other alpha blockers, or can be used for patients which are not surgical candidates. But also alpha-methylthyroxine is a PO medication. All right, we're coming to the end of this presentation. We have reviewed pheochromocytoma, adrenal gland insufficiency, gluco and mineralocorticoids, the effects on laboratory, and specifically we talked about aldosterone antagonism or spironolactone. We talked about the humoral stress response and which patients you should consider a steroid stress dose to avoid steroid withdrawal symptoms.